I bet you thought we were doing cardiology today. Well, we're not, because I didn't prepare cardiology. I didn't even remember that it was next up. So today, and for the next several weeks, you get pulmonology. I'm sorry, this is just what we're doing. I think this is a really good little segue. I will work on prepping my cardiology content, and that way we can just do this one first because it's already ready, and then I'll just exchange it for cardiology. It is such a beast. There is so much content in that one that the episodes are going to be either very long or a million teeny tiny ones, depending on how people like. Do you like bite-sized information, or do you want like a 40-minute episode every single episode for several weeks? You let me know. I don't care. I am just going to be doing the simple stuff, which is pulmonology. So we're doing pulmonology. And I hope that you guys are having an excellent week. I have been recording out the wazoo with some friends, new and old, and I'm so excited to be having all of these different specialties on the podcast. If you are a various specialty PA or healthcare provider, I'm looking at anyone at all, I would love to have you on the podcast. I think that the more people get to see different specialties, different job types, different everything, the better it is for them. And it's better for everyone, patients and providers alike, to build a sense of community and develop some transparency and debunk some of the mystique of being in medicine. I think I might even be able to convince one of my attendings to come on the podcast, which would be so fun. And I won't say who, and I won't say when, and I won't say anything more about it than that, regardless of all of that stuff. Okay, I always say that. I've noticed that I say so and regardless in every episode. So I'm going to try to see, I did it again. Okay, segue into intro. Go. This week, I wanted to briefly talk about study tip-wise, making a plan. We've talked about this probably a couple times before, but I wanted to specifically mention how I created plans for the EORs when I was in clinical year. For the EORs, which are the end of rotation exams in PA school, these typically happen, as they say, at the end of a rotation. So you can study for this either winging it and just going by the topic list and trying to hope that you get all the topics in before the test, or you can be a little bit more organized than that, which is what I would recommend. For my class in my clinical year, I actually did not have EORs. I didn't have to take a single EOR in clinical year, for better or for worse. Not a one. That doesn't mean that I did not study as if I was going to take an EOR. We did have a couple tests throughout the clinical year. They were just more segmented, and they were kind of everything and not just the specialty you were rotating in. I don't know if that totally makes sense, but it was interesting. It worked. I passed the pants, so it definitely did the job. But even still, now, I know for sure my program is now doing EORs, and I know that most schools do EORs, so I thought that it was important to kind of still break down the plan that I did. Essentially, I would take a calendar and print it out on a piece of paper, and using a pencil, I would assign different topics to every single day, and then move those around based on the schedule that I had at work, whether that was me doing 12-hour shifts, which I usually didn't study on those days, and then I'd study for a couple hours the following day. Whereas if I had an 8-hour shift rotation, then I would study after work. Sometimes I even had rotations that gave me an hour to an hour and a half off during the middle of the day, and I would even schedule in, I'm going to study 1 or 2 topics while I do it. I think that there's a couple ways you can make a plan. That's how I did it, and then I downloaded it into a computer, and then basically I just lived and breathed by that. Everybody loves their Google calendars, so I know people can even make the argument that you want to put the topics into your Google calendar, which I've heard about that before. I didn't do that. I liked having a separate academic calendar for like content versus schedule, because my schedule got really crazy during clinical year. It's up to you. It's just an idea. Take it or leave it and run with it. I'm going to go ahead and start talking about pulmonology now. This week is going to be just a couple topics. I am planning to discuss the couple pleural effusion type conditions. So, big title, pleural effusions. Types, chylothorax, empyemas, and hemothorax. Then next week, I think I'm going to do pneumothorax, chest tubes, and thoracentesis. So I'm going to put the procedures with the pneumothorax. Then after that, we'll do lung malignancies and pulmonary nodules and mediastinal disorders, and then we'll be done. So it'll be like 3 weeks. So that'll be great. This week, though, we are talking about pleural effusion, so I'm going to go ahead and get us started right off. A pleural effusion, by definition, it is a collection of fluid which develops in the pleural space when there is an imbalance of pleural fluid production and absorption. It is a condition that is evidence of a disease and not necessarily a disease in of itself. Bear that in mind. It's a sign of something more. So if somebody does develop a pleural effusion, it's your job to figure out what it is as well as treat it, because you are going to develop symptoms from having fluid in the lungs, but you also need to figure out the source of that problem because it may not alleviate all of the symptoms, or you may unveil other problems. 3 types of pleural effusions that we will be reviewing today. 1 is an empyema, 2 is a chylothorax, and 3 is a hemothorax. Empyemas are direct infections of the pleural space. Chylothorax is fluid from the lymphatic system which accumulates. And then a hemothorax is gross blood, either from trauma or malignancy. Now, those are the 3 sub-umbrellas. What I want to guide you into next is actually differentiating pleural effusions based on the type of fluid that is produced. Transitive and exudative are our next subtypes. Or I guess you can do pleural effusion, subtype transitive versus exudative, and then assign your hemothorax, chylothorax, and then empyemas to each category. Transitive pleural effusions occur when the anatomy is normal, and it actually occurs due to increased hydrostatic pressure or decreased oncotic pressure. Remember that. It's not a failure of the anatomy. Exudative, there is compromise of the capillaries, which are weak or leaking, and or it's a failure of the lymph system to clear. Hint, hint. The transitive pleural effusions are what I'm going to kind of go through first real quick. Your differential or most common causes is, first off, congestive heart failure. You need to remember transitive and congestive heart failure go together. Exudative, the most common is cancer. Now, for transitive differentials, you have congestive heart failure, nephrotic syndrome, and cirrhosis. Exudative, you have cancer, pneumonia, pulmonary embolisms, and TB. Think infection and inflammation for exudative, and then everything else for transitive. The presentation, diagnosis, and treatment is all going to be the same, so I just want to once again review the umbrella. Pleural effusion is a collection of fluid within the pleural space. It is an evidence of a disease. That fluid is either transitive or exudative. Transitive fluid is fluid that occurs when the anatomy is normal, and it is a function problem. That leads you to things such as congestive heart failure, which is in my mind, I remember it as a misfunction. Nephrotic syndrome, again, a misfunction of a different organ. And cirrhosis, again, a misfunction. Exudative is due to capillary compromise or failure of a lymphatic clearance. So that is, in relative speaking, an anatomic problem. Exudative, I remember exudate, infection, and inflammation. Cancer, pneumonia, PE, and TB. Your presentation for a pleural effusion is going to be a patient who presents with dyspnea, cough, chest pain, or perhaps is asymptomatic. The physical exam is a question that you get very frequently on the boards, in my opinion, and that is first to essentially focus on your pulmonary exam and then a couple vital signs. For your pulmonary exam, the things that they always talk about are percussion, auscultation, and fremitus. Pleural effusion, everything is decreased. Okay? Percussion, breath sounds, and auscultation, everything is low. There's dullness to percussion, There is a dullness on auscultation, decreased breath sounds, everything's low. That's because fluid, think about it, if you're building up a bunch of fluid in a closed space, it's going to be dull when you percuss, like if you have a balloon and you're tapping on it, whereas if you have a balloon that's filled with air, it sounds much different. These pleural effusions can be an incidental finding, so you're likely going to have these physical exam findings, but it may not necessarily be a symptomatic concern by the patient. Of note, oftentimes these patients develop hypoxia, shortness of breath, difficulty breathing, dyspnea, and they can even have bulging between their ribs, so don't forget those oddball physical exam findings. For diagnosis, chest x-rays are your test of choice. They are simple, they are quick, they are immediately interpreted if needed, so they're great. If you need to figure out the diagnosis and you're suspicious of pleural effusion, order a chest x-ray. We often get AP chest x-rays in the real world, but the lateral chest x-ray is one of the more helpful views. The sign that you're going to look for on a chest x-ray are blunt costophrenic angles. So the sharp angle from the curvature of the diaphragm on either side in combination with that rib spaces kind of going down on the lateral side of your image, it forms an acute angle. If it's flat, that is evidence of a pleural effusion. Fluid can be trapped and appear like a mass, so you have to kind of bear in mind a wide differential when you're seeing these. Bear that in mind as well. Next, thoracentesis is your gold standard diagnostic and therapeutic treatment. When you do thoracentesis, you're essentially going into the chest and removing that fluid. And then you're sending it off to a lab to get studied. So by removing the fluid, you often alleviate some of the symptoms. Then when you send it to a lab, you often get interpretations back on what was in the fluid that then tells you what the condition is. Oftentimes in the real world, we can just look at the fluid and kind of tell you what's up. So if there's purulence, if it looks like pus, it's probably pus, and we call it an empyema. If it looks opaque white, that is lymph fluid, so think more like a chylothorax or a thoracic duct obstruction, things like that. And if it's gross blood, it's a hemothorax, usually. Now, Light's criteria is how you differentiate between transidative and exudative fluid, and this criteria, although the bane of my freaking existence, was actually asked on my board exam, so I feel like it's important for me to describe Light's criteria. It is three criteria or three rules, and if you have one or more of those rules positive, then it's an exudative fluid. So your three criteria are fluid protein to serum protein ratio greater than 0.5, your fluid lactate dehydrogenase to serum lactate hydrogenase ratio greater than 0.6, and your fluid lactate dehydrogenase is greater than 2/3 the normal serum lactate dehydrogenase. I think that this is an interesting one. It's hard to remember. I just feel like it was just not something I could keep straight. The way I ended up doing it is, generally speaking, you need greater than half or greater than 0.5 for all of these criteria. And you're essentially saying that there's more protein and more damaged tissue, like due to inflammation or lactate, in the fluid. So it's always more protein and more lactate in the fluid. So that means that your fluid protein to serum protein is greater than half, greater than 0.5. Your fluid lactate to serum lactate is greater than 0.6 or greater than 0.5. And then your fluid lactate is greater than 2/3 the normal. So you're kind of going up, 0.5, 0.6, 2/3. If any one of those are positive, it is an exudative fluid. Go down your differential for exudate, which the most common type of exudative fluid was malignancy, yay, or pneumonia or PE. Just remember that. There are a couple other things that you can test for. You can get a culture and sensitivity. You can check an amylase. You can put things under cytologic evaluation to see if there are any malignant cells, and kind of all of those things together. It's more common to do the thoracentesis after you get a chest x-ray. And the treatment is to treat the underlying condition. So remember that thoracentesis is therapeutic and it is diagnostic. You're going to want to treat whatever condition is revealed by this. And then you can always upgrade to a chest tube as opposed to a thoracentesis if necessary. And remember, I'm going through thoracentesis and chest tube specifically in a different episode, which is why I'm not going into the details of that. So you're going to have to listen to the next episode if you want to know more about thoracentesis. Honestly, I think that this is a really simple condition that people overcomplicate, and I don't want you to miss any of these questions. They should be easy, simple questions. Don't miss these. And remember that you can always go through your physical exam and create charts to compare and contrast conditions, which is what I like to do. I made a pneumonia, pneumothorax, and pleural effusion compare contrast chart, and that's what helped me keep the physical exams straight and how I made sure not to miss those questions on the exam. That's what I would recommend doing. I hope that you take that advice, bring that chart with you next week to this episode, and we'll review then.